Teresa, I was interested when I heard you in your summing up comments there saying, we're all ears. This is what this is about. What did you learn today? Is there anything you're going to walk out of here going, didn't really think of that one before?
Not anything particularly that hasn't come up in conversations already. And I guess, kind of thinking, why has it taken us as a collective so long maybe to be having this conversation was one of those questions I spoke. But I suppose I did think, look, there are a couple of real quick wins because there's actually so much consensus about the most important issues and the foundational steps that we need to put in. So that's probably my answer, that I think there is a commonality. If it was a focus group that we were doing, I think, there are different opinions within it, but I think we've hit saturation on the issues, and that's not surprising, but I suppose it was heartening to hear, and I think there's a real basis for moving forward and for building
and that's
forward.
A great starting point to be at. And Anna and Ejner, I'm really interested to hear your perspectives on where you think we are in this country, having listened to the contributions. Anna, you might start us on that over the course of the day.
Yeah, thank you very much. I think you're doing really well, and I can see a collaboration of Scotland and Ireland just developing. I can see a joint meeting. I think it would be really interesting because I think we think the same, similar size, similar ambitions, and I think it might be really interesting. And of course, perhaps by proxy, we get into Horizon, which is my aim.
So are you in? Ejner, are you in?
We're not in. We're not in yet, but we're hoping. No, I think on serious note, very much what we just heard, we're all saying the same thing. Now, we need to truly compare notes, truly have a global collaboration, global platform. In the lunch break, we were discussing new definition of precision medicine that I would like to publish in first issue of our journal. And I think it needs to be global platform because otherwise we're not going to win.
Ejner, do you want to add to that? What do you think what's happening here?
I have the same impression. Ireland is really on a good way. And what I think is very positive is to hear kind of the positive attitude there is among all stakeholders, all decision makers we have heard today, towards developing and implementing personalized medicine. So Ireland is facing the same issues and problems as we face all over, but they're very open and also very open to collaborations with European projects and so on. So I think that's indeed very positive and definitely a good way forward.
And Colm, when I was listening to Deirdre there from Roche saying that they feel that there could be twice as many medical interventions at half the cost to the public, do you believe and accept that at this stage?
Yeah, and she also said, I think, that we could reduce harmful medical interventions that are not. It's astonishing the power of this. And as you look at the 100,000 genomes projects, and some of us were over at the million plus projects that Ireland is now a member of in the EU, what personalised medicine, well, means to me is not just additional, more effective treatment, but also eliminating potentially harmful treatment that isn't effective by predicting who will respond. And the range of potential applications is really, people talk about genetic illness, and we've heard about cystic fibrosis, oncology, but it goes right through to pharmacological interventions in depression, for example. So we haven't even begun to see the potential application of this yet. It really is a paradigm for healthcare for the future. I've no doubt about that.
We dealt with a story on the programme today, which I'm sure you heard, about the developments in Alzheimer's treatment. And Professor David Robinson was talking to me about it, and he was explaining how you will need an entire infrastructure for testing to ascertain whether somebody is suitable for this new drug. And for me, that was saying, this is what personalised medicine looks like. That's the investment before you get to reap the advantage of something like that. That's essentially what we're talking about, isn't it?
Yes, and there's huge investment required, and that's why the collaborative approach to the strategy we're about to launch is important, particularly the sponsorship from the Department of Health and the Minister. That's really critical. But they recognise that first of all, for existing service, it has inconsistent quality. It doesn't tap into all this potential, and we need huge investment in order to ride the wave of the current technology and the current advancements we're seeing, yet alone what the next few years will bring, which we don't know yet.
And Orla, I'm conscious that I'm having this conversation with Colm and I'm talking about money. Straight away, that's where you get to with this. Do you feel that that is the biggest stumbling block when we start talking about personalised medicine?
Yeah, I mean, it's money, resources, infrastructure, all of these things that, the first thing that comes to mind for me is, as someone who is like a current patient, I have cystic fibrosis, I had a double lung transplant, I'm currently on dialysis, hopefully going to get a kidney transplant. So when I look at my own journey through the health system, there's some instances where I get excellent care, and there are some instances where care is staggered, is not as good as it should be, is non-existent. And these are real problems that we have now with what we have, with what we need to provide. So when we add in this wonderful, ambitious series of goals that are being presented here and that are so heartening to hear about, I'm so concerned about how can we hope to implement this, even with this funding, if we can't get the infrastructure we currently have right.
Does anybody want to address that point?
Yeah, I definitely would like to, because I found these talks, especially the second talk on healthcare costs, very interesting. And to me, they definitely clarify that we have a problem, but the problem resides within our current systems. And to me, these stories just tell me that we need to rethink how we are doing these things. We need to rethink how are we financing health systems? How are we financing treatments? And we need to think much more broad and much more long-term in order to get into a framework where it will be possible to provide the treatments that has been asked for today, and which today is considered very, very expensive. Because if you put it into the right framework, the picture might become very different.
Yes. Anna.
Could I add to this? So this is all true, but when you look at individual drug that is applicable to small number of patients, of course this is expensive. But there are these other things we discussed today, such as pharmacogenomics, where in fact you make savings for the health service. And I think it's very, very important to put both sides in the same equation and then make, sort of summarize the good and the difficult and see what comes out at the end. And I think there is that health care cost avoidance is a huge thing that needs to be looked at very well nationally and then globally, because that's also very important. If we prevent adverse reactions to drugs that cost millions and billions Europe-wide or worldwide, we can balance this against these treatments for rare conditions that are very expensive.
Okay, Ejner, yeah.
One more comment, because one thing is that we are now discussing about paying for treatments. But if we are now also starting to look much more into prevention and personalized prevention. And if we go into that part, I mean, this will also cost money for the healthcare system, and who is going to pay? And the only way you can handle this is to look at it in a broader and a longer term scale, because then the whole economics of healthcare systems will be different. And maybe we will have higher costs today and for some time. Eventually, it will be cheaper. And another thing which I think is also very important is, what is the endpoint we are looking for? Is it to have some good cost benefit on the treatments, or is it to have a healthy population? And I think this is kind of what we need to look at.
That's
and this is kind of where maybe the overall picture is colliding with, let's say, financial people looking at it. So there's a balance here that needs to be.
I'm just going to check. Sorry, Orly. Go ahead.
Yes, may I just say something just on that? and I realize I'm talking about a very specific patient group here, but I just wanted to sort of talk about a little bit about, the CFTR modulator drugs that are available, and many of them are available now to people in Ireland with cystic fibrosis, thanks to a lot of hard work and campaigning, and the work of many people who are attending this conference, right? But for example, there's a small group of 35 children, the ages of 6 to 12, who cannot access Kaftrio, which is the first drug to treat the cause and not just the symptoms of cystic fibrosis. And it's these 35 kids, I don't understand, because when we're looking at, like, say, cost effectiveness there, right? These kids getting access to this drug now, before they get to, say, my age, right, and need like a double lung transplant, it's proven that it will improve not just their lives, but the cost that they will accumulate in regards healthcare in this country. There'll be less hospitalizations, less intravenous antibiotics, less need for other new therapies as things move on, less need for double lung transplants. So this all affects healthcare cost overall and in the longer term for Ireland. So I realize I'm using very specific study example here, but why then can't those children have access to that medication?
Colm, I assume that question is for you.
Yeah, I'm happy to. We're very frustrated with this, including the obviously patients, their families, the doctors treating them are very frustrated, and this pertains, as Orla correctly says, to 35 kids between 5 and 11 who are heterozygous for this 508 mutation. And it's frustrating to us because the drug company Vertex, who have made huge profits, have onboarded other groups of patients as the indication for the drug has expanded, including kids with the same mutation over 11 years of age. And it's a huge frustration to us, and the clinicians involved have written a letter as recently as a couple of weeks ago expressing their frustration as to why the company involved won't expand the drug, as it's done for other patient groups as the indication is expanded. And the HSE has invested hundreds of millions into this drug to making it available for exactly the gains and benefits that Orla describes. And for us, it's huge frustration that for a relatively small number of people at a vulnerable age, that drug can't be expanded in the way it was before.
Are those negotiations between Vertex and the state, are they still ongoing?
Yes, our position is that we want the drug, as the clinicians do, as the patients do, and their families do. We have a responsibility also to make sure that we get the best value for money, because we have to spend money on lots of other things. And for us, there's a principle involved here where there's been a lot of money spent and invested in this drug. And as the indications broadened for other groups, the company responded by making the drug available for relatively small numbers, but changed what they had a pattern of behaviour and inclusion they had before.
All right.
By saying they wanted more money for this group.
Okay, I'm going to leave that one there out of respect to our audience who are here to talk about personalised medicine in a broader sense. But you have answered that. I have lots of questions here in front of me on Slido, but is there anyone in the room who would like to stand up and ask a question first before I come to this? I have somebody over here with a raised hand. We'll get a microphone to you.
Thank you. I'm Laura McCullough from the National Centre for Pharmacoeconomics, and just want to make 2 points. So one point that was raised is that we should consider the costs of adverse events avoided by switching patients to targeted medicines. And I think it's fair to point out that in our evaluations in the National Centre for Pharmacoeconomics, we do consider those costs, and those costs are part of the cost effectiveness analysis that we do. So those costs, lifetime costs, I might add, associated with adverse events avoided and also new adverse events that may occur with the new treatments, those are taken into account in the cost effectiveness analysis. And then another point that I might add as well is that Michael Barry earlier mentioned that an awful lot of the evaluations that we do, our conclusions are very often not deemed cost effective at submitted price. And what generally happens, or what happens, I would say, in more or less all of those cases, is that the applicant company, so the drug company, then approach the HSE to start negotiations. And we in the NCP inform those negotiations by informing the HSE as to what price that drug would be considered cost effective. And those negotiations very often then lead, or more or less I would say 100% of the time, lead to eventual reimbursement. And our stance would be, if the company are eventually going to offer that price, it would be much quicker for everyone in terms of access if that price was offered in the first instance, because the price is eventually attained. So there's often a delay seen in terms of access of treatment, but that delay is not, and often it's the decision maker or the payer where the finger is pointed to, but that's not the whole picture.
Okay, and I accept absolutely, thank you for making that point, but I do want to move away from that topic now to more general questions, because that's what we are here for. Anybody else in the room want to stand up and ask a question? Okay, well, let's come to some of our questions here that have been submitted over the course of the day. In the morning presentations, patients were mentioned often, but not as key stakeholders in the process. Do you see a role for patients? Teresa, do you want to take that one?
Absolutely, yes. And while I didn't list out all the different stakeholders when going through the slides in terms of that stakeholder engagement, I think patients and the broader public and their families are absolutely at the heart of it. And regardless of what topic we're talking about, whether it's regulatory frameworks, whether it's preferences, whether it's economics, whether it's patient pathways, absolutely at the heart of it. Public-private partnerships, really any of the topics mentioned today, I think that's the core.
I think there was more of a focus on that in the afternoon, to be fair as well, on patient involvement and protection of data and so on.
Absolutely, and I just point that I think it's one of the opportunities that we have in Ireland, that actually we have a very engaged public patient care between the PPI networks, between IPOSI, between the charities, umbrella group and so on. And we have a public that is really, really supportive of health research. And we acknowledge that. And I want to say that as a health research board, don't take that for granted. And we want to grow on that. We want to maintain it. We want to sustain it. So I think that voice and that input is absolutely critical, because this is all about benefits for patients.
Okay, so we have a question here on the key milestones. What are the key milestones to implementation? And who is accountable for the delivery of personalised medicine in Ireland? Who's in charge? No one here, it would seem. Does anyone want to take that?
I suppose all such questions will channel through the HSE. I might well. For once, there is relieved there were other people on the panel when you're asking questions, so I can look around over my shoulder before I answer. But for our strategy, we'll be setting up an office, and that office will have a very simple role. It'll be a very difficult role, but a simple one, which is to implement the strategy. And we're beginning. We've got some money to start off with. We'll be appointing additionally much needed counsellors. We'll be looking at additional posts that are much needed in the system. We'll be looking at the lab infrastructure in year one, a workforce strategy in year one, and a directory of testing services in year one. So we've got a busy, when this office gets going, it's going to have a lot of work to do. But ultimately that office, like the Cancer Control Office years ago, will become the engine driving change through which Mirish and his colleagues, if he's still here, will be getting the funding every year. That funding will be the end product of advocacy, of people making cases, and all of that way things work together. And that will be the office charged with driving our genetics and genomic strategy.
Here's another interesting one on the structure. Can the HRB build anything into its funding mechanisms to build trust with the industry, or is it a case of provide the money and then step back? So how closely will you be working with industry, I suppose, is the question.
Yeah, and I think this is a very live question for us, because it's not something in our remit that we would have any direct contact traditionally. I think, and it builds on the question that you asked last, because genomics is one part, but not the totality of personalised medicine. I think that's been very clear here today, personalised medicine, personalised prevention. So again, I think what we have seen from other countries is that at a minimum, you need your Department of Health, Education and Science and Enterprise sitting around the table, and all of us, like are here today, convening around it, and the agencies of the state can come together. So that, I think, is something that we have to aspire to. That's what we've seen has worked in other countries, and it can be led by the academic system driving it initially, or health, or enterprise, but you have to get those three pillars together and their agencies. I think if we can do that, and I think we have a national science and innovation strategy, it's called Impact 2030, and the 5 top funders of research have a governance structure, and I'd love to see that being the vehicle through which we can all navigate these issues.
I see a ticking clock in front of us, and it says 0. Is that for us? Are we done? Unfortunately, we can go over by another couple. Well, let's chance it anyway, and we'll see if Muirish comes up and gets us off. We know we're in trouble. Let's take another look now at some of these questions coming through. Where should the decision on how to spend the health budget take place, given the high costs but high personal benefits of certain targeted therapies? I think that's a question for our friends down at the end here.
Could you repeat the first?
Yes, absolutely. Where should the decision on how to spend the health budget take place, given the high costs, but the high personal benefits of certain targeted therapies? It's back to the moral question again, isn't it?
Yeah, well, I can try to start. I think we all know that, and it's the same all over the world, that scientific advisors or clinical advisors advise but do not make policy. And I, within the last few weeks, heard a fantastic lecture, award lecture of Patrick Vallance, who some of you might have heard during the pandemic, who said very clearly in Edinburgh, giving his award lecture, that scientific or clinical advisor who starts making policy rather than giving evidence becomes not efficient, because nobody ever believes him or her anymore. I have taken this as my mantra for the future. I provide the evidence, but my ministers have democratic right to decide the policy. And I think we need to remember this. But we need to give the right advice. We need to have all the possible evidence, and there is still evidence gathering as far as precision or personalized medicine is concerned. The best possible evidence, a lot of evidence, and then decisions to be made.
Thank you very much, Anna and Ejner and Colm and Teresa. Do you want to add something?
Yeah, just a very short comment. And I think, to me, the answer to that one is very clear, because we are living in a democracy, and we are selecting governments to take control and run these things, so they need to do it. It's our decision makers and politicians who is making the decisions. But they need to be helped, and this is also what you were saying, to make the right decisions, because often they don't know what the right decision is. So this is where we come in and to tell them how it could work and how it should be.
Well, thank you all very much indeed for taking part in our discussion. I'm sorry it was so short. The clock ran away with us a little bit, but I hope you got a sense of some of the questions that were coming through. And now I'm going to hand over to Dr. Mairead O'Driscoll, who's going to close for